Hello, friends. I always enjoy speaking on the treatment of femoral neck fractures in the young. It's one of the most interesting and controversial topics in orthopedic trauma. The focus of this presentation will be on reduction techniques in managing these challenging and anxiety-provoking injuries. I have no potential conflicts of interest with respect to the content of this lecture. We're going to start this discussion with anatomy, particularly the vascular anatomy of the femoral neck and head, because it seems to influence so much of what we believe about the influence of timing, method of reduction, and fixation of these injuries. As I mentioned, we're going to focus on reduction techniques, both open and closed, and I'll argue that you can be successful with both approaches, provided that you achieve a quality reduction, and we'll talk a little bit more about what that means. These are high-energy injuries, unlike their geriatric counterparts. They result from axial loading and abduction as mechanisms of injury and are associated occasionally with femoral shaft fractures. And we need to be careful about these injuries and missing them if we are managing an associated femoral shaft. As you listen to the information I'm about to give you, I want you to think about how you would approach this patient that I met almost 10 years ago. He was a 28-year-old software engineer, motorcyclist. It was his isolated injury, and he was healthy and a non-smoker. Numerous questions that immediately occur to you. We will focus to some degree on surgical approaches and mostly cover techniques for reduction. Any talk on surgical techniques needs to be grounded in a solid understanding of anatomy, particularly for surgeons. Let us start with the capsuloligamentus structures about the hip joint. There are three groups of ligaments that we need to be familiar with. The pubofemoral ligament, the lateral and medial iliofemoral ligament that originate from the anterior inferior iliac spine and are oriented in an inverted Y configuration, and the posterior ischiopubic ligaments. Knowledge of these ligaments and their function is not purely academic. One must know that the iliofemoral ligaments, for example, need to be taken off of tension with hip flexion to begin a manipulative reduction maneuver. We will return to this later. The vascular anatomy of the femoral neck and head are also vital to careful reduction tactics and implant placement that do not further embarrass the femoral neck and its head of its blood supply. Classical anatomic investigations shown here using dye injection demonstrate the paramount importance of the intracapsular retinacular branches of the medial circumflex artery on the perfusion of the femoral head. More recent anatomical studies have shed light on the importance of the medial and anterior neck vascularity afforded both by the inferior retinacular artery from the medial femoral circumflex, but also the ascending branch of the lateral femoral circumflex within the anterior retinaculum of Whitebrecht. The latter perfuses nearly half of the anterior inferior femoral neck. This is critically important for those performing an anterior intracapsular approach for reductions or attempting placement of a medial buttress plate where these structures may be injured. Numerous injury and technical factors have been identified that predict outcomes, while well-established risk factors such as Powell's angle or the verticality of the fracture or the initial displacement are all out of the control of the treating surgeon. The quality of the reduction very much is controlled by you, the surgeon. Remember that quality does not necessarily mean anatomic, but rather a qualitative judgment made with postoperative radiographs, as mentioned in the classic papers that I've referenced here. Let me address maybe the most obvious next question, which is whether one should approach injuries like the one I'm presenting at the beginning of this talk with an open or closed reduction. I will come right out with my recommendation to the younger learners in the audience, which is based on all of my years in practice, as well as a series of studies that my colleagues and I have conducted over the past 5 or 6 years. We started with a systematic review and meta-analysis of comparative studies of open versus closed reduction. And we found that other than higher infection rates with open reductions, there was no difference in the incidence of avascular necrosis or non-union. Now, of course, you're probably thinking that these mostly observational studies probably didn't account for the greater injury severity among patients that ended up getting an open reduction. And this stimulated me and my team to conduct a study to test this hypothesis. We'll come back to this. Nevertheless, I believe strongly that all orthopedic surgeons that take call and care for these injuries should first master an open reduction technique, as the skills required will firstly improve one's ability to obtain and maintain a reduction via closed means, and secondly, understand what an anatomic reduction looks like under direct visualization and how corresponding imaging looks. And finally, and most importantly, will lower any fear-based threshold for avoiding an open reduction when it's really necessary. The indication for an open reduction is when the fracture reduction is not satisfactory in any plane of imaging by closed means. This has been shown to be the most reliable way of judging quality of reduction based on radiographs and is the technique that my group used in the studies that are to follow. Of note, if you read technical articles on reduction techniques in our journals and our textbooks, you will encounter what I call an absolutist faction of surgeons who would insist that every young patient with a displaced femoral neck fracture gets an open reduction. That is what I was taught, and I have learned to question this philosophy over the many years of my practice since my training ended. In North America, the predominant approaches are the Watson-Jones anterolateral approach and the inferior limb of the Smith-Peterson or Hoiter direct anterior approach. Suffice it to say that in a cohort of some 80 patients treated with one of the two of these approaches in roughly even numbers, the rate of acceptable reduction in both coronal and sagittal planes was exactly equal at about 80%. Whether I'm planning on an open or closed reduction, I set up my operating room and position the patient in exactly the same way. I prep the injured side free on a radiolucent table. I do not use a fracture or traction table. I bump the injured hip in order to aid in getting a lateral image. Neuromuscular paralysis is critical for successfully obtaining and maintaining a manipulative reduction. And you will want to prep, you will want your prep to be inclusive of the iliac crest so as not to lose access to the proximal limb of one of your open approaches, which extends as proximal as the anterior superior iliac spine. My favorite tools for manipulating and reducing fracture fragments include clamps and chance pins as joysticks. These are images from the patient I presented at the beginning of the talk. I used a 2.7 millimeter reconstruction plate to support a large segmental fragment of the inferior medial neck, but the modified Weber clamp with one tine in the subcapital neck and the other in the anterior base of neck was critical to correcting varus alignment and apex anterior angulation. Chance pins used as joysticks are another powerful aid in manipulating fragments, restoring length, and correcting sagittal plane deformity. Don't forget to prime your K-wires or have them prepared within the distal fragment for provisional stabilization as soon as the reduction is achieved. An even more powerful clamp can be borrowed from your pelvic instruments. Both the Jungbluth and the Fehrbuf clamps can be applied over screws in the neck, potentially in conjunction with chance pins, as shown in the image to the left, to successfully reduce your fracture. Before I move on to closed reduction techniques, let me return us to the case that got this whole discussion started. I saw our 28-year-old software engineer who had the motorcycle accident later in the morning, and after no other injuries were found, I was able to arrange to get him to surgery early afternoon that same day. I performed an open reduction using a modified Smith-Peterson anterior approach to the hip. I already described some of the reduction techniques I used, and here are the final postoperative images. I judged the reduction to be adequate by directly visualizing the fracture site and was happy with the spread of my screws and the reinforcement of my fixation with a medial buttress plate. I used 2 lag screws anteriorly to further close down the side of tension failure and a positioning fully threaded screw posteriorly to strut out the zone of comminution in the posterior neck. My standard postoperative protocol calls for touchdown weight bearing for 12 weeks, and he did very well for a few months at least, and we'll come back to his story a little bit later in this presentation. Now that we're comfortable with open reductions, let's see if we can safely apply some of these principles and techniques to achieve successful closed reductions. Let us start with indications. Most surgeons would accept that a minimally or valgus impacted fracture with minimal sagittal plane imbalance can be fixed in situ with closed techniques. Patients with highly comminuted, potentially unreconstructable fractures, or those with major contraindications for further open surgery may have a relative indication, as I thought this patient, who was badly injured in a high-speed motor vehicle accident and had underwent pelvic packing for bilateral pelvic ring injuries with a nearly circumferential subcutaneous degloving injury. The last point on this slide here is related to where you are on the learning curve of reducing these fractures by closed means. Early on in my career, I opened every young femoral neck fracture, as I mentioned earlier. But as I gained experience, I learned that I could do more and more by closed and percutaneous techniques without compromising patient outcomes. I'd like to share with you my 4-step technique, which is an adaptation of the classic Ledbetter described technique. I start by making my small direct lateral incision for implant application and where I prime my Kirschner wires in the distal fragment for provisional fixation as soon as I'm able to obtain an adequate reduction. Then I flex the hip in order to relax the iliofemoral ligaments and externally rotate to open and adjust any translation in the coronal or sagittal planes. Next, I internally rotate in order to close the apex anterior deformity. Then I extend the hip in an abducted position to err on the side of valgus alignment as I tighten the pubofemoral and iliofemoral ligaments to lock in the reduction. Slight adduction then corrects for any residual valgus alignment, and the limb is held in position here while provisional fixation is run into the proximal head and neck fragments. Percutaneous reduction techniques are also highly effective and frequently complement my closed reduction techniques, as illustrated in these intraoperative fluoroscopic images, which show a closed reduction with a primed Kirschner wire. I have shared with you the useful clamp and pin applications along the anterior neck that can help reduction of sagittal plane malalignments. A similar effect can be achieved with the use of a percutaneously applied ball spike pusher, and then advancement of that primed Kirschner wire to hold our reduction provisionally. Now that you're armed with all of these new closed reduction tools, how do you think we should approach the polytrauma patient I introduced to you a little bit earlier in this presentation? I performed a closed reduction, and I would not argue with anyone that the reduction was not perfect or anatomic, but I considered it adequate given the patient's condition and was happy to get this done within 48 hours of a very significant polytrauma injury. I certainly had my doubts about whether this was going to hold up, but sure enough, he healed without evidence of avascular necrosis or non-union. And here are some images from his 2.5-year follow-up, after which he had returned to full function as a janitor. Let me begin to close this talk by summarizing probably the most controversial research study that I've ever published. I assembled colleagues at 11 other prominent level 1 trauma centers around the United States to test the dogma that open reductions led to better outcomes. After extensive effort to control for other confounding factors like injury severity, we found more than a twofold increase in the risk of reoperation, mostly for non-unions and avascular necrosis among those undergoing open reduction. This was consistent with the systematic review that I presented earlier and really compelled me to question my own practice. I want to be clear, these results do not support closed reduction in all cases, and certainly don't suggest that an inadequate radiographic reduction should ever be accepted. Rather, it convinced me that when my radiographic reduction looks close to anatomic in orthogonal planes, that the fracture may not do any better having an open reduction to make it anatomic, and I may avoid complications by avoiding doing so. Also remember that while neck shortening of the femoral neck is not good for hip joint health and function because it decreases the abductor moment arm, thereby increasing joint reactive forces. Making your construct length stable doesn't seem to be a winning strategy either, as evidenced by the catastrophic failure rates of the proximal femoral locking plates that were used for these injuries. With our knowledge of the fragile soft tissue envelope that nourishes the femoral neck and head, and this cautionary tale of avoiding length stable fixation, what then are we supposed to think of the constructs that I used after what I would consider adequate open reductions illustrated here? They both failed. But why? Was it because the injuries were so terrible that I didn't do a good enough job reducing them? Or did I underestimate the biologic cost of the open reduction, or the potential to make things overly rigid and prevent the gradual compression necessary to allow for healing? I don't know. Our patient came back at 4.5 months with obvious failing hardware and a non-union. Luckily, I was able to salvage this 28-year-old's hip with a Powell's intertrochanteric osteotomy, and this got him to union and a pretty satisfactory functional result. I'm showing you 5-year follow-up because you need to follow these patients with these sorts of injuries for at least 2 years to know that the joint is hanging in there, the fracture is healed, and you're free of avascular necrosis, which can present late. Remember, the goal is a quality reduction, not necessarily one that's anatomic, and these are the parameters that I generally judge my intraoperative fluoroscopy or assessment of reduction. I'm looking for less than 2 millimeters of displacement and less than 5 degrees of angulation in any plane, although I may be willing to accept a little bit more given the circumstances, as I did in this particular patient. I think you can still be successful using these parameters. So I'll leave you with this pseudo-successful case as a reminder of many of the learning objectives from this talk. Understand the anatomy, particularly the vascular anatomy of the femoral neck. I think its tenuous nature explains much of the risk of poor outcome after these injuries, be it non-union or avascular necrosis. While quality of reduction is probably the most important surgeon influence factor predicting outcome, much of the dogma about the emergency of treatment and the use of open reduction for every case should be questioned in light of literature published over the past few decades. Other factors that we know to be important, such as degree of shortening at union, may not be easily countered, nor should it be necessarily. At this point, we do not have a way of maintaining anatomic length without promoting non-union and hardware failure. Finally, While new approaches to fixation convey an understanding that these fractures need to experience some degree of compression without shear, we need to demand the highest possible quality of evidence prior to concluding that we are actually doing any better by our patients. I thank you for your attention and look forward to a fruitful discussion